Well, good afternoon,
Good
everyone.
afternoon, everyone, and welcome to today's Lunch and Learn webinar session titled ACS FluFOBT Program, a Proven Approach to Increase Colorectal Cancer Screening. I'm Shannon Robertson, Director of Clinical Quality with the Louisiana Primary Care Association. We are pleased to have Dr. Keith Winfrey, Chief Medical Officer for the New Orleans East Louisiana Community Health Center, as our presenter for today. He's an assistant professor of medicine at the Tulane University School of Medicine, has served on the American Cancer Society Speakers Bureau since 2014, and is also the current Clinicians Branch Chairman for the Louisiana Primary Care Association. During this presentation, Dr. Winfrey will provide education on the evidence-based FluFOBT or FluFit program based on current American Cancer Society recommendations, and provide practical steps on educating the community and implementing a program in your respective organization. Just a housekeeping item, in order to stay within our time frame, we will hold questions until the end of the presentation. All participants will be in listen-only mode. Please type your question throughout the broadcast in the question box located on your webinar screen. If we do run out of time, you will be able to email your question and we can follow up with you after the webinar. Our contact information will be displayed at the end. Thank you for participating in this presentation. Dr. Winfrey, you may begin.
Great, thanks, Shannon. And thank you for the opportunity to speak to you this morning about the FluFOBT program. I will be referring to it this afternoon as the FluFit program. And as we begin talking about the colorectal cancer screening, I must share our personal story. When it comes to our organization, we are excited that we reached 70% screening in 2016. But I say that only because it's been a journey to get to that point. Back in 2011, we really were not focused on colorectal cancer screening in any significant way. It wasn't until HRSA, through the UDS, mandating that we begin to report our colorectal cancer screening numbers, that we start to pay attention to it. And much like you all, at this time of the season when you're looking at your UDS data and preparing to present it, you see areas that you've done well in the previous year, areas that you need to improve on. And so for us, in 2012, our colorectal cancer screening rate was at 3%. Exactly, it was horrible, 3%, and that was just by provider recommendation and providing. And so it wasn't until at that point that we began to say as an organization, let's make this one of our priority areas going forward. Let's look for evidence-based interventions and opportunities to improve our screening rate. And along the way, as we've come across evidence-based approaches, we've started adopting them and incorporating them into our practice. And it's helped us to achieve the goal that we had last year. And so the program I'll speak today is one of several interventions that, okay. I can't go back at this. Well, all right, so did you see the slide? So what I wanted to start off, and we'll come back to the story later. Colorectal cancer, the third most common cancer in the U.S., 135,000 cases expected in 2017. It's the second deadliest cancer in the U.S. with over 50,000 cases expected this year. It's highly preventable, highly treatable, and there's over 1 million colorectal cancer survivors in the U.S. Again, the colon is a large muscular tube about 5 feet long. Its primary role is to absorb water and salt from food and to store waste matter. The rectum is that last 6 inches of our digestive system. And so when looking at a screening test, it has to be one that can detect cancer within any aspect of that 5 feet long organ. And so that's important to know that this is the organ that we're referring to, and this is where it's important that we have a screening test that can address that. Cancer that begins in either the colon or rectum is what we're referring to today. It's commonly referred to as colon cancer. So whether it's in the colon or rectum, it's colon cancer or CRC. And what we know is that colon cancer typically develops from precancerous growths called polyps. And these polyps can develop in the lining of the colon or rectum. finding and removing polyps can prevent colorectal cancer from occurring. And so that's the ideal way of preventing colorectal cancer, is being able to identify the polyps and remove them. So who can get colorectal cancer? The easy answer is anyone. Men, women, all ages, all races, all ethnicities can get colorectal cancer. But the important thing to take away from this presentation is that screening can prevent you from getting the disease and dying from it. So what are some of the risk factors that are important for developing colorectal cancer? Well, by far, age is the most impactful risk factor. What we've seen from evidence-based studies is that once we get to the age of 80, the number of polyps and colorectal cancer increases dramatically in someone's lifetime. And so starting at age 50 is when we begin to see a dramatic change in those rates. And the chance of getting colorectal cancer increases as we get older. So who's at highest risk for colon cancer? Anyone who's had a personal history of polyps, colorectal cancer, inflammatory bowel disease, conditions like ulcerative colitis, Crohn's disease. Anyone with that history is at high risk for colon cancer. Also, anyone who has a family history of colorectal cancer or polyps or hereditary cancer syndromes would be considered high risk. Those individuals will have a separate screening interval recommended by their primary care provider, and so it's very important that they follow with them for additional information as far as testing. The approaches that we're referring to today will focus primarily on those at average risk. When considering a screening or screening test, essentially we're looking for asymptomatic cases. If someone has symptoms of colorectal cancer, typically at that point the cancer is pretty far advanced. And so when we're looking at screening, we're considering individuals who are showing no symptoms at all. And so this screening test that we offer needs to be a routine part of our healthcare checkups, similar to how patients come in for blood pressure assessments or glucose assessments with their diabetes. The screening test that we need for colorectal cancer needs to be something as a routine part of our everyday practice. Colorectal cancer screening is unique in that we have tests that are able to screen for cancer and tests that are able to screen for polyps. And so that makes it a little bit unique in that we can actually detect precancerous lesions in the colon and rectum, and thereby preventing cancer from developing altogether. And looking at screening rates nationwide, currently looking at colorectal cancer screening rates using the fecal occult blood test, flexible sigmoidoscopy within the past 5 years, or screening colonoscopy within the last 10 years. The most recent data as of 2014 says that about 67% of the U.S. population is up to date with their screening. Included here I have the top 10 states that have screening rates, with Massachusetts leading it. And you see at the bottom that Louisiana ranks around 34th in its screening rate, and that's at 65.8. So we still have a significant room to grow in terms of reaching our population that are eligible for colorectal cancer and eligible for screening. And so we have a ways to go. Why tests? I touched on this earlier. The tests that we have can, one, prevent cancers from developing altogether by finding and removing polyps, or it can detect cancer at an early stage, a stage in which, if treated and removed, increases survival rate dramatically. Also, testing is important because typically at the early stages, patients can't feel abnormal growths. They don't feel polyps. They don't feel any early signs of cancer. And at those stages is when treatment was most effective. If patients come in after they've developed symptoms, chances are the 5-year survival in those cases are dramatically reduced. So the only way to find polyps and cancer is to get patients tested early and often. What are some of the screening tests? Real briefly, There are two most commonly used screening tests in the United States are colonoscopy, which is a direct visualization inside the entire colon, or stool-based tests, where patients take a sample of stool and they use special testing techniques to identify hidden trace amount of blood in the stool. The two most common stool tests are the fecal occult blood test and the fecal immunochemical test. Recommendations for these tests: patients who've had colonoscopies, if the colonoscopy is done and there's no polyps identified, screening interval can be spaced out to every 10 years. Depending on the type and the number of polyps, that interval can decrease considerably. But nevertheless, patients who are able to get the colonoscopy, that's probably the best test for them to have, because not only can they detect cancer, but they can also detect polyps. And then once it's done, the interval, again, anywhere from 3 to 10 years in between screening. For those who are unable to get the colonoscopy or are afraid of having the colonoscopy performed, doing high sensitivity stool-based testing is also equally effective in terms of preventing cancer deaths. And again, we talked about the two types earlier, the guaiac and the immunochemical. Flexible sigmoidoscopy is a recommended test. It can be done every 5 years. It's limited in scope and how far it can reach within the colon, and it has to be repeated every 5 years. Also of note, patients that are 60 and older tend to have colon cancer develop more in their proximal colon, an area of the colon that the flexible sigmoidoscopy can't reach. And so it then makes that test a little less effective the older that patient gets. So flexible sigmoidoscopy has been phased out, is being faded out. It's rarely used now in the U.S. healthcare system. Again, colonoscopy allows us to directly visualize the colon. It can remove polyps. Again, if the patient has very little or no polyps, the interval for follow-up is every 10 years. There are certain preps the patient will have to go through and will require a minimum amount of anesthesia to have the test done. And so those are all considerations that the patient has to take into mind when they decide on the test that they would like to have. Stool-based test. Cancers often leak small amounts of blood, small trace amounts that cannot be directly visualized. And so these specialized tests allow us to identify trace amounts of blood in the stool. And if found, patients absolutely need to be followed up with a colonoscopy. So although the stool tests are great screening tests, if they are found to be positive, the patient will absolutely need to be followed up with a colonoscopy to rule out any signs of cancer. There's a variety of brands and collection methods that we can use for the stool-based test. We encourage you, if you're going to employ that method, that you use a very highly sensitive and specific screening test. The Hemocult Sensa is one, OC Auto. There's a list of approved FIT or fecal occult blood tests that we can recommend. So anyone who wants additional information about the ones that are approved by ACS or been found to be more effective, just let us know and I can send you a list of those once we finish the webinar. This is just another example of a fecal immunochemical test. This one, the HemoSure, you see there's a probe. Essentially, the patient will collect their stool specimen on a tissue, use the probe to kind of probe inside the stool, and then place it back into the container, seal it up, and then mail it back in. With the immunochemical test, one stool sample is generally all that's required for this initial screening. So what is the FluFit or the FluFOBT program? It's an evidence-based intervention with proven effectiveness in increasing colorectal cancer screening rates. It's been shown to be effective in community health center settings, and it can be implemented and supported by your support staff. So although clinicians may be involved in initial planning. The actual implementation and intervention itself can be done by support staff, which makes for a very efficient screening service. Why would someone consider the FluFit? Well, colorectal cancer screening, particularly using a stool-based test, mirrors a lot of the same recommendations that we see in certain influenza populations, influenza vaccination populations. The recommendations are very similar. And so I put here side by side some of those characteristics of each of those preventive tests that makes them similar. Influenza vaccines recommended annually, as is the stool-based test. People age 50 and older should be prioritized. So if you have a limited supply of influenza vaccine, you're trying to prioritize those who are 50 and older. Well, again, that matches up perfectly with those who are at average risk for colorectal cancer. Most organizations have standing orders, policies, or flu clinics in place so that nurses can essentially administer the flu shot without having to go and speak to the provider for each patient. The same thing can be done with the stool-based test. And what we know both with influenza and with the stool-based test, they both save lives. So how does the FluFit program work? So this is a basic, simple workflow. If you set them in a flu clinic, the patient arrives for their flu vaccination. They go through an eligibility criteria where the staff looks at their age. If they're between 50 to 75, then they go into a direction where they're being asked further questions about colorectal cancer risk. So has the patient had a colonoscopy in the past 10 years or a flexible sigmoidoscopy in the last 5 years? If no, has the patient had a fecal occult blood test in the past year? If yes, then they can go ahead and have the flu vaccine and that visit concluded. If the patient has not had their fecal occult blood test, then the FIT test can be administered at that time with an envelope for the patient to either mail back or return within 14 days. The important part of this intervention is the follow-up. And so after that 14-day period, if no return has occurred, staff should be placing a reminder call asking the patient to return their FIT kit or mailing it back into them. If it has been returned, then there should be a documented return date recorded in the patient's chart, and then notifying the patient when the results come in, whether the results are positive or negative. If it is positive, there needs to be a plan in place to refer them over for a diagnostic colonoscopy for further evaluation. Health center staff essentially recommend screening and provide kits to all eligible patients when they get their annual flu shot. Either the high sensitivity fecal occult blood test or the FIT can be used. Patient then takes the kit home, completes it at home, and then either mails the kit back or returns it to the office. Again, the FluFit program is done in several locations throughout the country. It's been well received and accepted by patients, and there are consistent studies showing effectiveness in various settings, including community health centers. This is just an example of some of the evidence that exists for the FluFit program. There are several community clinics, primary care clinics, and a couple of managed care sites where this intervention has been introduced. And with each of those sites, they've noticed an increase, a significant increase in screening rates. In their community clinics, it went from a 32.5% screening rate up to 45.5%. And one of the other primary care clinic studies, it went from 42.5 up to 55.8. And again, the staff that were required to implement this intervention were either nurses or medical assistants or additional clinical staff. So how do you set up your FluFit program? The first thing you have to do is assemble a team. So you have to designate someone as a champion or a coordinator who's going to take the lead and make sure that the remaining steps are implemented, and also do the day-to-day follow-up of patients as they come in, tracking them, monitoring them as they come in for their flu shot. The team members can include clinicians, medical assistants, nurses, or health workers who are trained to provide flu shots and fit kits. You also need to plan specific roles and tasks for each member of the team. The second step, which is a very important step, is training the team. So staff training should include educating them on facts regarding flu shots and why it's important, colorectal cancer screening and why that's important. The staff needs to be familiar with the procedure of completing the fit kit and the fit kit they're going to distribute. They also need to understand the workflow. They need to organize and understand the workflow for when the patient comes in, and need to practice that a few times to make sure that everyone understands when the patient comes in, this is when we're going to complete the eligibility criteria, this is the direction they go in depending on their results. Everyone needs to be familiar with the eligibility criteria and also the tracking practices. The second step, in addition to training, is patient flow. So you need to identify which staff will work with just the flu shot patients, which staff will be working with those receiving the flu fit. Because not everyone coming in for the flu is going to be eligible. They may have already had their fit that year. They may already be up to date with colonoscopy. So for them, they just need to come in, receive the flu shot, and leave. So we need to designate staff that can handle each one of those groups so that the clinic will flow efficiently. Also determine how a patient will be guided to the flu shot only versus the flu fit areas. Again, how you go about doing the eligibility, who's going to set that up, and how will you designate those roles. This is probably the most important aspect of this program. You need to offer the fit or the FOBT before giving the flu shot. Otherwise, the patient may just receive the shot, walk out, and then you lose that opportunity to provide that screening. Assessing eligibility. There needs to be an eligibility algorithm posted. It needs to have a system that's easy to access, and whether it's electronic health record or whatever system that you identify, it needs to be one that can be quickly and easily accessed by the staff to cut down on time in the eligibility process. And then also consider offering the fecal occult test to those where it may seem possible that the patient is outside of their recommended interval. There's a question about whether it's been slightly longer than a year or slightly longer than whatever their recommended follow-up time was. It's best to go ahead and offer them the test, even if it comes back later that they were in that interval. So when should a patient not be offered the FIT test? If they're less than age 50, there's no need. If they've already had a colonoscopy in the last 10 years, if they've had a FIT test in the past year, those are the essential ones. Also, if they have a personal history of Crohn's disease or ulcerative colitis, if they have a personal history of polyps or cancer, or if they have a family history of polyps or cancer in a family member that's younger than age 60. And then lastly, if there's any rectal bleeding or blood in the stool or other symptoms, these all suggest increased risk factors, and they should be directed to the primary care provider for additional counseling and recommendations. The final steps, you need to designate the date, time, and location. So some people have separate days of the week or separate times of the day in which they offer flu clinics. Everyone needs to understand when those times are, the location that the flu clinic is going to be offered. Also develop systems to support tracking and follow-up. Follow-up is key in this type of intervention because not only are you handing out the FIT test, but you have to make sure these patients remember to complete it and bring it back in. And then finish preparations for the flu fit program by advertising and again going through the workflow a number of times to where everyone gets it. I was listening to a college coach interview about a month ago. He was a very successful coach, and they were asking him what are the keys to their success. And they thought he was going to say, well, we practice repetition so that we don't make mistakes. But that wasn't his response. He said, we go over and over to where the patient, to where our team can't get it wrong. Right? So instead of going through the process over and over till you don't make a mistake, they go over the process over and over again until they can't get it wrong. With this type of program, it's best to take that approach. You want to review it often enough to where your staff has it down packed and they can't get the steps wrong. Lastly, don't forget reminder calls and postcards that you can mail out to patients to return their fit kits. It's important when talking to patients that you educate them about the importance of colorectal cancer screening, that they should take it important, that they remember to bring the kits back in a timely manner, ideally within 14 days. And if the kit has not been received within 14 days, there needs to be a telephone call or postcard reminder sent out reminding them. The sooner that patient can get the test done, the better. Studies have shown that once you get past 7 to 14 days, the rate of return drops off considerably. And then lastly, there's a few guides or tools that are available to assist you if you want more information about the FluFit program. Of course, you can find additional information on the American Cancer Society website. There's actually a section dedicated to the FluFOBT program. Has a full implementation guide and materials. It's very helpful. A lot of that information is what I use in this presentation today. It talks about the background information, patient eligibility criteria, screening recommendations, education. It goes step by step throughout the entire process. Also includes workflows, charts and tables where you can document roles and responsibility. Very, very useful guide. There's also a flufit.org website supported by UCSF. The physician who developed the FluFit program has done a lot of research with it. He's a primary care provider out in San Francisco. If you go to this site, you see several of the publications of the research he's done, as well as additional steps in how to implement this program in your practice. Several acknowledgments. The physician I was just mentioning, his name is Michael Potter. He was a former steering committee member of the National Colorectal Roundtable. There's several other individuals who were very influential in getting the program started and getting research together, and so we definitely want to appreciate them and thank them for their efforts as well. That is all I have at this point, Shannon, and so we can go ahead and open up the phones for questions.
Okay, thank you, Dr. Winfrey. At this time, we have unmuted the lines for questions. As a reminder, you can also type your question in the question box located on the webinar screen. So if you have a question, please feel free to ask at this time.
Okay, so about this list, do you feel like there's clear understanding of who's working on this list from that meeting?
Hello, if you have a question, please ask at this time. We do have one question so far in the chat box, Dr. Winfrey. What is the cost of the FluFit program for uninsured patients?
So that cost will vary depending on the negotiated rate that the clinic has with their lab company. For us, it ranges anywhere from $10 to $25 for the test itself. That's a shot, and then for the vaccine, it's whatever the vaccine cost is for your organization. And so most places, I think in this area, the flu shot is about $20. And if the FIT test, let's say, is $25, then you are looking at about $45 for both. And if you have a sliding fee scale, the patient may be able to get that cost reduced some depending on their income.
So, Winfrey, when did you guys implement your FluFit program?
So for us, we added this past year, 2016. And so we spent time during our annual staff training orienting them on the aspects of FluFit and letting them know that this is going to be an intervention that we wanted to employ this year. So 2016 is when we implemented ours. And with us, we implemented the FluFit along with several other interventions that have been found to be effective. So it was hard to just separate out the impact that the FluFit had by itself. But we did offer FluFit. We have care coordinators who are making calls. We're doing physician reminders. We're doing also patient reminders. So we combined about 4 or 5 different interventions to get patients back in.
Okay. Well, I think that is, Dr. Winfrey, did you have something else to add?
So while we're waiting for a few more questions, what I was saying in the beginning is that back in 2012, our screening rate was about 3%. And it was at that time that we decided to make colorectal cancer screening a focus for our organization. And so from then forward, we started looking for evidence-based approaches and interventions that will help us to improve our screening rates. And so we've adopted several along the way, and the FluFit is the one that we just incorporated last year. And so we were able to reach 70% in 2016. And so while we were excited about that, it took quite a bit of work and effort for us to get there.
Thanks. Okay, and I think that is maybe all of the questions we have. We can give a few more seconds while I give closing comments to see if there will be any more questions. I would like to take a moment again to thank Dr. Winfrey for conducting this presentation today and for always being a strong supporter of the LPCA and the efforts being done to raise those colorectal cancer screening rates. We will send out a copy of the slides to all registered attendees and post the recording to the LPCA website. And if there are no more questions, this will conclude our webinar presentation for today, and I thank you everyone for participating. Have a great day.
It looks like there's another question in the chat box.
We do? Okay.
So is there an approximate cost comparison between like FluFit versus FluFOBT using like I think it's like the quiet test?
Dr. Winfrey?
I'm sorry. So there's a cost difference between the FIT and the GUAIAC test. You just want to make sure that if you're using the GUAIAC test that you have the one that's that's highly sensitive. There are various types of GUAIAC tests, and so you just want to make sure you have the right one that will make a difference in some of your screening rates and the effectiveness of your program. Essentially, those tests run anywhere between $10 and $20, and so depending on. Now, also, what you have to consider with the GUAIAC test is there's certain meal adjustments or dietary considerations the patient has to make, and the patient has to typically submit 2 to 3 stool specimens as well to ensure high sensitivity. And so there's a little bit more that's required of the GUAIAC test. But there are some very effective GUAIAC tests that are available.
Okay, good advice. Thanks so much, Dr. Winfrey.
And just if we wait a few more minutes, well, we still are planning to develop and roll out or help to support medical neighborhoods throughout the state. So for those participants that are in the Louisiana area, we'll be looking to come to different regions throughout the state this year, working with community health centers and their local endoscopists to work out a referral pattern for anyone with a positive FIT or anyone who's open and interested in getting the screening colonoscopy. And so stay on the lookout for that. We will be sending information out. That's coming from the Louisiana Colorectal Roundtable, and those efforts will be picking up here in 2017.
Okay, and then looking at our question box, I don't see any other questions. However, lines are still unmuted. If anyone has a question they would like to ask, please feel free to do so. Okay, well, I think that is all the questions we have for today. And again, thank you so much, Dr. Winfrey, and thank you everyone for participating. And again, if you have any questions, feel free to email myself. I will forward that information to Dr. Winfrey, and I will send out our email contact information at the close of the webinar presentation.
Great. Well, thanks again, Shannon, for having me.
Thank you.